This mini lecture is going to cover microcytic anemia, and we'll also take a look at thalassemia. So anemia can mean any of several problems that involve suboptimal red blood cells or the function of those red blood cells. And the diagnosis suggests low hemoglobin, low hematocrit, and even a low number of red blood cells. So all of these problems involve a reduced amount of oxygen that is circulating in the body, because the red blood cells do carry oxygen to the tissues and the cells. So the World Health Organization and the CDC identify anemia as a hemoglobin of less than 13 in men, which also correlates with less than 42% of hematocrit, and less than 12 in women, less than 36% hematocrit, and less than 11 in pregnant women. There are slightly higher values of hemoglobin and hematocrit that are considered standard, and those are usually in either the developed world versus the undeveloped regions of the world. But as a rule of thumb, the estimated level of hematocrit is 3 times the value of hemoglobin. So for example, if you have a patient who has a hemoglobin level of 13, then you can estimate their hematocrit to be about 39%. When we think of how we categorize microcytic anemia, it's categorized based on the amount of the size of the red blood cells. So your size is micro, which means small, and the RBCs indicate cytic, so microcytic. It's been linked to nutritional deficiencies, particularly a deficiency in diet intake or uptake of iron. The small size of the red blood cell is identified by one of 3 indices of the red blood cells and the mean corpuscular volume, so your MCV values. You can usually make a diagnosis of microcytic anemia by identifying the presence of anemia combined with a low MCV. Some of the causes would be blood loss or a decreased production of red blood cells or an increased destruction of the red blood cells. Looking at the relevant blood test, you have your CBC levels, where you would notice a decrease in hematocrit and hemoglobin, your size of the mean corpuscular volume. The normal is 80 to 100, so anything out of that range would be indicative of your micro or macro. The MCHC, which is your mean corpuscular hemoglobin concentration, measures how full the erythrocyte volume is filled with hemoglobin, so a normal would be 31 to 36. Your serum ferritin, your body's major iron stores protein, and correlates with those total body iron stores. So your normal ferritin should be anywhere between 16 to 300 for men and 4 to 161 for women. And you may also see a decrease of this with iron deficiency anemia. You'll see an increase in the total iron binding capacity to bind, because that capacity binds iron calculated from the transferrin levels. So your normal is 250 to 460. So that would be elevated in iron deficiency anemia. The incidence of iron deficiency anemia has been estimated to be 1 to 2 to 2.5 among pregnant women, and 1 to 6 in persons older than 75 years of age. And this is usually easy to correct and remedy unless it's caused by some type of a GI malignancy. So iron deficiency is less important in the differential, even though it remains the most common cause of microcytic anemia. The reticulocyte counts are immature red blood cells, and those are associated with the red blood cell production. So you'll see these decreased in iron deficiency anemia and also in anemia of chronic disease. And those normal levels are 33 to 137. And then your serum iron levels are usually decreased also in iron deficiency anemia, and those levels range from 50 to 175. Some of the classifications of anemia: when we look at microcytic, your MCV is usually less than 80, which is indicative of either iron deficiency anemia or thalassemia. When you have normocytic anemia, your MCV is at 80 to 100, and you may see this with anemia of chronic disease, as well as sickle cell anemia, and acute blood loss and early IDA. And with macrocytic, your MCV would be over 100. So you have larger cells, your macro, so the size of your red blood cells are larger. And that will be seen with vitamin B12 deficiency, specifically pernicious anemia, which is your most common form, and also folate deficiency. With the macrocytic anemia, the MCV is usually less than 100, as I said, and you're iron deficient. You'll see a hypochromic pattern with the low MCHC. And this is usually the most common cause of anemia. Most of the causes are related to postmenopausal women and men who might get a chronic GI blood loss. Also, you see this with menstruating women and children who have nutritional deficiencies. Most adults in the United States take in and absorb enough iron in their diets, but about about maybe 10% of the daily iron intake is really absorbed in the stomach and the duodenum and the jejunum. So the average healthy adult usually absorbs about 1 to 2 milligrams of iron a day, and the same adult loses an amount of iron equal to that's ingested and absorbed just by maintaining homeostasis. As we look at screening, we follow the United States Preventative Service Task Force, and that recommends that current evidence is not sufficient enough to assess the balance of the benefits and harms of routine screening for IDA, especially in asymptomatic pregnant women. It is a grade B recommendation, so they do not recommend routine screening for all asymptomatic adults. The CDC recommends periodic screening for pregnant women and non-pregnant women of childbearing age, and to screen all non-pregnant women of childbearing age for anemia every 5 to 10 years, starting in adolescence. So you can see that there's some differences in what the guidelines are talking about, and this is what we talk about when we tell you that guidelines are different in many, many of the resources that you're looking at. They also say annual screening for women at high risk for iron deficiency would be women who have heavy menstrual cycles or some other type of blood loss or have low iron intake, and if they've previously had a diagnosis of iron deficiency anemia. So you see a lot of young girls come in, and even women in their 40s come in with excessive menstrual blood loss. When we're trying to get the history on our patient, many times they're just asymptomatic. They may have very vague symptoms. They could have symptoms of fatigue. They may feel weakness. Many people are just tired in general. So those are some pretty vague symptoms. But they also may have some episodes of lightheadedness. They could get dyspnea on exertion. So these are some of the things that we want to ask them when we're actually doing the history. Asking also about their menstrual and their pregnancy history. Do they have any melena? Do they see any hematochezia? Do they have a history of pica? Asking them, do you chew on ice all the time? Or is this common that you have to have ice all the time? I have a friend who has severe anemia and from having gastric bypass surgery. And he was so anemic that he was buying 5-pound bags of ice and keeping them in his freezer. Everywhere he went, he would take this cooler full of ice and he would just chew all day long on this ice. So one of the questions that you need to be asking them is, do you have a tendency to be chewing on ice all the time? Think about asking regarding the medications they're taking, such as the antacids, the H2 blockers. Are you taking protein pump inhibitors? Are you using over-the-counter anti-inflammatories or chronic aspirin use, zinc, manganese? Because a lot of these patients will be taking over-the-counter anti-inflammatories and they really don't think that they're causing them any problems because they're over-the-counter. And they correlate over-the-counter with being safe. So if they're taking over-the-counter medications and they're not really thinking about the possibility that they're taking too many, it could cause them to have some bleeding issues. Ask them also if they have any history of inflammatory bowel disease, celiac disease, any type of gastric surgery, or any type of surgery that they've had relating to their stomach. Family history. Is there any family history of colon cancer, bleeding disorders, sickle cell, anything in the family that could correlate, as well as social history? What kind of diet do you have? What kind of foods do you eat? What's your iron intake like? Do you smoke? Do you drink? So all of this is part of your history. When we're thinking about doing our physical examination, these patients, they can present with many different symptoms, as I said, and many vague symptoms. But you really need to think about how you're going to do a physical exam on them, because anemia cannot reliably be diagnosed by your clinical presentation. Only when there's really any severe findings, such as with chronic anemia, do you see some of the changes. Many patients with a facial mask of fatigue, sallow-colored skin, pale mucous membranes, tachycardia, those usually are where they've had some type of chronic issues going on. And you should also be looking at their nail beds, because prolonged blanch response in the nail beds, like more than 3 seconds, would be indicative of iron deficiency anemia. Most patients don't even present with that type of sign, though, as well as looking at the mucosal changes, the brittle nails. Do they have reddened appearance of their lips? Do they have any fissures around their mouth? Does their tongue have atrophic glossitis? In addition, looking for, their cravings of certain things. Some people crave cotton. Some people crave clay. Some people crave dirt. So, as I said, also the ice chips. So really honing in on some of that. Looking to see if they're tachycardic. Do they have any pulmonary edema? If they have possibility of heart failure. And that would be for somebody that has some really chronic low hemoglobin levels. Check for splenomegaly or hepatomegaly. Do they have anything going on in the abdomen? Do they have spoon-shaped nails, which is very common in people who have iron deficiency anemia? What about the creases of their palm? Do they get cold hands and feet? Do they say, I feel cold all the time, or my feet feel cold all the time? And then thinking about what their differentials are. Could they have thalassemia? Could they have lead poisoning? Could they have anemia of chronic disease? There's a lot of diagnostic tests that will help you to differentiate one versus the other. The initial diagnostic testing is focused on obtaining a CBC, from which a red blood cell count and the red blood cell indices are there. So your MCV, your mean corpuscular hemoglobin, and the mean corpuscular hemoglobin concentration, those are all isolated with that. If you see a low red blood cell count, hemoglobin level, or hematocrit, then you may be able to identify that anemia. When you're suspecting someone with iron deficiency anemia, it's really simple to just do a serum ferritin test, which is a very reliable test of low stores of iron, and provided they don't have any type of advanced liver disease. If you have a serum ferritin value of less than 30, then it's considered to be pathological. When the ferritin level falls, the total iron binding capacity will rise above the normal range. So look for a high TIBC. And if the ferritin level drops, if you see that drop in ferritin and a rise in TIBC, then the serum iron level will also fall, as will the transferrin saturation. So you need to probably be doing some secondary testing on them too, and looking for some different things. So how are we going to manage these patients? Well, first we have to identify the cause and treat the cause. So the first thing we want to look at in these patients is to give them the occult blood cards for 3 times and see if they test positive for any of that. That's one of the things that we need to be doing, because we can pick up a lot by using those cards. And then increasing their iron, the dietary iron. Supplemental oral iron is best if it's given as ferrous sulfate, 325 milligrams a day, 3 times a day. And 10 to 20 milligrams will be absorbed from the total daily, intake of iron if the iron level is low. In more severe cases, the level of the absorption will increase. So you should be rechecking their red blood cell indices and the iron values every 2 to 4 weeks after you do start them on some type of regimen to see if the effectiveness of the oral regimen is really doing what it needs to be doing. If there is no measured improvement in the anemia after 1 month, then you really should be looking at some other type of underlying cause of the deficiency. They should continue to take their supplements for at least 3 to 6 months after the normal levels have been restored. When we're giving them the supplemental iron by the parenteral route, then that is when you've had the documented failure of therapy with the oral, and you should calculate that dose by subtracting their MCV from the normal lower range. And this value is really what the total number of milligrams of iron to add according to the MCV. So in addition, you could add 1,000 milligrams to the dose to cover the storage of iron in the body. The daily dose of a supplemental parenteral iron is right around 1,300 to 2,000 milligrams of iron a day. And then that preferred route would be IV. When you are giving them, in the elderly, giving them low-dose iron supplements may be better to improve their lab measures, and it's tolerated a little bit better with them because of the risk of constipation. And we talked a little bit about the types of iron supplements. There's ferrous and there's ferric. The ferrous iron is the best absorbed form, and most are available in the pills. And most of these pills do contain the ferrous iron. There are 3 types. There's ferrous sulfate, ferrous fumarate, and ferrous gluconate. All 3 of these contain 325 milligrams, and each contain a different amount of the elemental iron. And you're dosing them all at 325 milligrams also. The absorption decreases as the dose gets bigger, so it's usually divided into 2 to 3 times a day dosing. And this is really sometimes difficult to get the patients to take 2 to 3 times a day. But if you can get it in them twice a day, you'll be doing good. The most economic is your ferrous sulfate dosed at 1 tab a day, and you can do that weekly, and then you can try to do that for a week, give them 1 and then increase it to 2 and then increase it to 3. And what this does is helps the body to adjust to the changes, and they don't seem to get constipated as much as they do if you start really, blast them with the 3 times a day. And this is really in line with your 150 to 300 milligram daily dosing. We want to make sure that these medications are not, within the reach of children, just like everything else, and that talk to them about the common side effects, educate them about the constipation, the diarrhea, the dark stools, the nausea. A lot of patients will come in because they're concerned now because their stools are dark. But that's kind of something that would be normal. The other thing they come in sometimes with dark stools is if they've taken milk of magnesia, and they come in a panic because their stools are black. So you need to educate them that their stools might be dark from as well as the iron. But, if you take milk of magnesia for some reason, that could cause that also. You don't want them to take these with antacids or calcium supplements or any of the quinolones or tetras. And there is an increased iron absorption with vitamin C, which is your ascorbic acid. And we talked about follow-up. The Retic count should be increased probably in 7 to 10 days, but usually not ordered unless you're concerned about the specific diagnosis. So we're focusing on self-care and primary care management of the underlying cause. So when we talk about the self-care, we're talking about the dietary changes, the level of activity. Are they self-monitoring for their signs and symptoms of anemia? So if you think about patients with iron deficiency anemia, you need to really educate them on how to make sure that they're taking their medication on an empty stomach, and that, they're following all the, taking it with a small snack or taking it between meals, and to make sure that they're self-monitoring for any type of fatigue or shortness of breath. And, just kind of the normal things that you would think about. If they feel that like they're getting tachycardic or their heart is racing, teach them how to do their pulse. You should see the hemoglobin increase by 1 to 2 milligrams over a 4-week period, and you might want to give them a good month and then have them come back and you could check this. But generally, it's about 3 months to restore all of the iron stores. So by 6 months, you should start to see where their hemoglobin levels have become normalized. Thalassemia can be thought of as a differential for iron deficiency anemia, and the pathology is either related to depletion or mutation in the genes that code for the subunits of the protein component of adult hemoglobin. So there's alpha and beta globin chains. The alpha thalassemia is caused by gene depletion, and that creates a reduction of alpha globin chain synthesis. There are, where in contrast, I guess we could say, with beta globin chain, the only gene for the beta globin chain is inherited from each parent. So the mutation or the deletion of one of these genes results in beta thalassemia minor or beta thalassemia trait, which is characterized by a mild anemia that is usually asymptomatic. You'll see this more in people in Asian, African, and Mediterranean descent. And these individuals usually have a little bit more pronounced symptoms, and they're a little bit more severe, and they're diagnosed usually within the first years of life. Individuals heterozygous for the defect beta chains do have beta thalassemia minor, and patients with both alpha and beta usually only have minor symptoms. So the alpha minor may have that mild anemia with a hematocrit between 28 to 40 and an MCV of 60 to 75, and their red blood cell might be normal, or it could be just a little bit increased. And their Retic counts are normal, their hemoglobin electrophoresis is normal. So it's really a diagnosis of exclusion with these patients. The beta minor is a very modest anemia, so its hematocrit is 28 to 40, and your MCV is 55 to 75. Your blood smear is mildly abnormal, and unlike the alpha minor, you may see that there's some erythrocytes that display small dots on the periphery, which is called basophilic stippling. The Retic count is normal or slightly elevated, and electrophoresis may show some abnormal elevations. So it's really important to differentiate these milder forms from IDA, because of the treatment with iron in a patient with thalassemia can result in iron overload, which leads to life-limiting organ damage. So you have to be very cautious and make sure that you're diagnosing them appropriately. And the patients that do have thalassemia minor are often misdiagnosed with IDA, but they don't respond to the iron therapy, and they have those normal iron stores. So the thalassemias often require no treatment other than really watching the hematological markers. And if you diagnose microcytosis with mild anemia, then you should not be subjecting the patient to any further checks for iron deficiency if there's a distinct thalassemic etiology here. If these patients do have severe anemia, however, such as the one associated with major, and then they may need a transfusion regularly with red blood cells. So you'll be maybe seeing a hematologist for this. With minor, most patients, as I said, are asymptomatic, and it's found very incidentally when you're doing your CBC levels and it's showing that mild microcytic anemia. Their physical is not really giving you any kind of indication that there's anything going on, and there really isn't, as I said, any way to manage them, but you may want to talk to them about genetic counseling.